the analog trigger, and I'm presenting two cases of mine which give a slightly different post-trigger evaluation, and that's something which we're going to have a look at. So now, with PCOS or with high responders, the analog trigger has been one of the most important interventions which has lowered the risk of ovarian hyperstimulation and maybe improve the quality of oocytes, because it to a large extent depends on following the hormonal profile of nature. But again, that's again a different discussion. So let's go back to this lady who is at, I'll share the screen because that would give me a better idea into what's going on. So what we were planning to do is, so let's have a look at the first lady, and what we're looking at is, and this is, I'm going to divide this into a trigger on the day of bloods on the day of ovulation, and then post-trigger bloods, and which are normally followed. So let's say she's a 38-year-old lady who's coming in for the 4th or 5th treatment cycle, and she was going for PGTA, and we give her a dose of 300 because we wanted a good response. So what are the things which I see? And what do I do see is have a look at the FSH, and its FSH is 14.9. Now, what is the approximate maximum dose of FSH that you can reach on stimulation? It ranges between anything between 14 to 25, and you rarely see levels increasing beyond 25 international units per liter, and that's serum FSH when you're on a maximum stimulation. And what we know is that it doesn't make a huge difference trying to increase the dose. Now, the luteinizing hormone was 0.9, so that's a good stage, and so no sign of premature ovulation. A progesterone, again, 4.9, so that's within the normal zone. Again, a progesterone rise is a key indicator. So if your progesterone rise goes up to 15 or 20, even with an LH that is low, you're more likely to get follicle luteinization and disappearance of follicles. So you don't need to have a high LH to be able to say that you're going to go for a luteinization, and that's a misnomer. Progesterone may be an indicator or maybe a trigger to start the process of luteinization or collapse of follicles. Estrogen, again, quite high, and we gave a trigger of 2 ml of supercure. So let's look at the post-trigger bloods. Not a huge FSH rise. And again, what does the trigger do? The trigger releases FSH and LH. So not a huge FSH rise. A reasonable rise, but less than 15. Remember, we use a cutoff of 15. But what made me decide that I'm not going to re-trigger this lady and was the progesterone. The progesterone had risen post-trigger. That's 10 hours later. Post-trigger is 45.8. So have a look at recent publications. And when does progesterone rise? It starts rising just before ovulation, and just after ovulation, its rise starts getting significant. And so that is a very good progesterone rise and an estrogen level that slightly drops. In my personal opinion, I like to have the estrogen level drop because preceding ovulation, just before preceding and when the LH rise occurs, estrogen levels tend to start declining. In the luteal phase, estrogen also declines. So in my personal opinion, remember, some of this is very much my opinion of how I deal with my patients. And I think that is something which may be important. So we got 13 eggs, 6 blastocysts, 2 euploid, and she's now pregnant. So that is, it gives us a clear idea that the egg to follicle ratio was good. And what made the difference here? Not the LH, but the progesterone. And the progesterone gave me a hint that I should not re-trigger, because looking at the low, slightly lowish LH, and we want that LH to be greater than 15. Now, let's look at my next case. And this case is a lady who's much younger, is 28-year-old, and she was on 225 on a step down of 150 of HMG, and you have a look at the FSH. FSH is still around a normal level, not very high. It basically means that the stimulation was following a moderate pattern. The LH low, progesterone low, estrogen normal. Again, she had about 20 follicles. So what was my concern here? What is the problem here? Is it that some of the follicles are empty? Is it that some of the follicles are probably not going to get eggs? Why is the E2 not that high? She's not PCOS. She just has a good reserve. And so let me go one track back. So what drug did I use here? I used HMG, and that sometimes makes a slight difference in terms of your estrogen levels. Trigger done. 12 hours after trigger, we decide to look at the bloods. The FSH has risen. That's a positive sign. The LH has risen, but have a look at it. It's risen to 28.5. Fine, better than, greater than 15, international units per liter, but that's a reasonable moderate rise. Progesterone also has given a moderate rise, and the estrogen level has slightly dropped in here. What would you worry is how many eggs do we get? And so here we ended up getting 20 eggs and 6 blastocysts with 14 fertilized. So that's a reasonable estimate. I would have probably thought it. So the blastocyst conversion usually at a younger age is between 30 and 40%. So this probably followed that track. So here, what was my concern? My concern is that a slightly higher level, but not a PCO level E2. Is that a concern that will not give me eggs? But again, I've used HMG, which is more moderate in terms of its aggressive response. A moderate rise of both progesterone and LH, both indicative that the process of luteinization is starting. That's what progesterone tells you. So now, why is this important? Is again, let's go back to the triggers. So let's look at nature. In nature, the LH rise is 14 hours, plateau for 14 hours, and a 20-hour downward arm for 48 hours. So that is something which is phenomenally great, in terms of how nature functions. Anything that is shorter than nature, and that is the analog. So when you give the analog, rise for 4 hours, decline in 24 hours. So in 24 hours, your LH has disappeared. So doing an LH 24 hours later is useless. And then what is great? It creates a defect in the luteal phase of 24 hours. Have a look at HCG, and HCG goes on, and then a rise that goes on for about 7 to 10 days. And that's quite an extensive, leading to ovarian hyperstimulation. So this is in brief, some learning points, and some learning points is don't be scared in using the analog trigger. It gives you more information, gives you far more information about how the pituitary is working and what is the process of luteinization and what is your chance of getting more mature eggs, which is very much derived on granular cell change and granular cell luteinization, which means if your progesterone level post-trigger is higher, you have a better quality of granular cells, which means maybe better eggs. My theory again, which can be questioned. So that's the reason why you use it. Irrespective of estrogen levels, don't get scared about using the analog trigger, because even if you've got moderate estrogen levels, it seems to work quite well, and because it's using the natural trigger. And always do your post-trigger bloods. Thank you very much.